with limited accountability for where the funding has gone. How much has been utilized and for what purposes? The private sector has, again, simultaneously made tremendous strides in this space, but unfortunately we have heard that CDC has not been willing to engage and leverage private sector innovation. Why isn't the private sector being leveraged and better utilized, and what is the return on investment on the hundreds of millions of dollars we have invested in this particular space?
Thanks for those questions.
Dr. Layden, please. Thank you.
Absolutely. Thanks for those questions. I'll start with the investments to data modernization. The first investment occurred in 2019 with $50 million. The progress we've made in data and analytics across not just CDC, but at our jurisdictional levels is largely driven by COVID-related funds. Over the last 4 years, we've been able to produce or provide $1 billion to our jurisdictional partners for data modernization. We've seen great and tremendous progress. We've seen examples of electronic case reporting, syndromic surveillance, vital statistics, cloud capabilities across our jurisdictions and at the CDC that's allowing us to have the robust national situational awareness. To put it into context, over the last couple decades, $35 billion were provided to healthcare to modernize their health IT system. The amount of money that's gone to public health to modernize our system pales in comparison. Despite that, we've been able to make tremendous progress, and with continued and sustained funding, we will have the robust public health capabilities that our nation needs. To your question about the partnership with private partners, that is critical for the work that we do, and we have multiple examples. We're not just CDC, but our jurisdictional partners partner with private entities. We, for example, over the last year, as we stood up the Public Health Data Office, we've had numerous summits where we've brought in private partners, the local, state jurisdictions, and CDC programs to all come together, talk about the needs that public health has, and create innovative solutions.
Well, thank you. If you could provide a written, detailed account of how this funding is being used, again, to our office, we'd appreciate it very much after the hearing, of course. Dr. Hacker, the joint testimony mentioned the diabetes prevention program, which has been proven successful in preventing or delaying the onset of type 2 diabetes. The DPP is currently running unauthorized along with many other CDC programs, which causes us on the committee to be concerned about the agency's transparency and accountability measures. With over 38 million Americans living with diabetes, including myself, and its complications being the 8th leading cause of death nationwide, it's clear there are significant needs amongst our constituencies. How is the CDC consolidating its efforts, and what metrics is it using to ensure the methods brought by the DPP are leveraged in state and local communities? Please, again, this is for Dr. Hacker.
Thank you for that comment. So the DPP program is, I think, one of our finest examples of a program that CDC, where we used NIH data to develop a program that could be used at the state and local level. It is a national program, and we do fund all of the states to be able to implement the DPP program. Generally, we look to having community organizations that know folks within the community. They're well connected to the clinical system. This is a program that has been highly affected, and it is really geared towards people who don't have diabetes yet, but may be at risk for developing diabetes. And what we know is that if you participate in this program, and we know that this year alone, there's something like 700,000 people who are actually participating in the program, that they can reduce their risk of diabetes, actually getting diabetes, by over 50%. And after we have followed up, because we do strong evaluation to determine whether or not these programs continue to work, with which populations, where, how to deliver them, what we've found is that even in looking back at these programs, people sustain those changes that they've made and don't get diabetes. So our space really is in the prevention of diabetes. Now, we are involved to some extent in the self-management of diabetes, and we do believe that there has not been enough focus on educating individuals with the disease on how best to manage themselves so that they don't end up with the terrible sequelae of the disease, such as kidney problems or eye problems, things like that. So while we look at our programs severely, we are really, really trying to make sure that what we are delivering, and we do this also with our colleagues at the Centers for Medicaid and Medicare, because this is a program which is reimbursable, and we are very intent on making sure that the folks who need this program, that they get the referrals from their clinical perspective, from their physicians, and that they actually engage in the program going forward.
Gentleman yields back. I recognize Dr. Joyce, 5 minutes.
Thank you, Mr. Chairman, for holding this hearing today, and to our panel for testifying. For the CDC